everyone, welcome to
Lina and Rada Show.
How are you doing today?
I hope everything is going well with you guys.
Yeah. So we are here today recording a new session for you related to old TG versus new TG. Hope the previous shows were helpful and that you enjoyed and understood new things about the new TG. Today we are going to talk about the orofacial pain.
Yes, definitely. Yes, I mean, this is hard work, right, Rada?
Yes, we spent a lot of time.
Let me tell you guys that I don't know if you guys have been doing this exercise as well, probably. You know, the ones that are new to part 2, probably they are not doing this because you guys don't need it. But for all candidates, probably they are doing this same exercise. So they will know that this requires time, reading time, analysis, you know, we have spent quite a bit of time doing this, right, Rada?
Yes, exactly. Yeah. So, all right.
So, orofacial pain.
It's kind of jigsaw chapter, so they included different parts from the old one into this one. So, okay, so they have added in this chapter the post-treatment pain that were in the
last part of the OTG.
Yeah. So, like for instance, in OTG page 127, you found it in new TG 129.
Yep.
You have the different kind of definition of pain and the types. So they added a new one, the nociplastic pain. So there is a new definition. It's basically you do a diagnosis based on exclusion. I mean, it's not a one that we will.
I don't think that's the one that we are going to deal with.
Yeah.
Basically, in this classification, you found the other ones, nociceptive pain, which is basically the one that
we
touches us
more.
as dentists, you know, in everyday life. Because they put the example here, irreversible pulpitis is the typical example for nociceptive pain. And obviously, neuropathic pain, it will be something that most likely specialists like oral medicine or max fac, they are going to deal with that type of pain.
Yeah.
So that one is already out of our scope. And then they have this new one which is called nociplastic pain that has a very tricky definition over there. But apparently it's like the patient that has a pain.
Yeah, about central sensitization, and so you don't have an ongoing pathology, but rather a kind of a previous experience, a previous pain experience, and then it can trigger more pain when they experience kind of the same trigger. But I mean, this one is not really relevant.
I don't think it's going to be very relevant
our scenarios.
Yeah, true. Probably for part 1, right?
Yeah, part 1.
If they want to ask concepts and stuff like that.
Other than that, you still have the acute dental pain definition, the chronic pain, then the acute dental pain, where you have the table, so table 12, that you found in OTG at the very end for the medical practitioner, how to deal with the dental pain until the patient could see a dentist. So if you just want to go through it, feel free, but it's kind of the same. Other than that, so we have, it's pretty much the same.
I will try to mention that, yes, after that table that Rada just mentioned here, you know, that the one is pretty much the same that we had in OTG. Basically, they are giving everyone a roadmap about how to establish the need for analgesics. So if you see page 137 and box 16, basically that will be your roadmap to know if you need to choose an analgesic therapy for that particular patient. So first is just try to establish the kind of pain. If the pain is mild, moderate, or severe, that is going to dictate your kind of analgesic therapy. Second, we need to consider the potential effects of the analgesics, especially NSAIDs, which are the ones that, as we talk about in the very first session of old TG versus new TG, it was mentioned there. And
you have to consider the patient medical conditions, if there are any contraindications, and so on.
And the last one to need to keep in mind is if the patient can take the medication orally, because obviously oral administration is the preferred way for us. And if it is not possible, then you need to look for alternative routes to administer that. So that little box is quite important, because in your process of thinking about this, you have a patient in front of you, the patient has pain. Is that pain mild, moderate, or severe? If the patient classifies within these three categories, then we need to prescribe some kind of analgesics. Which type of analgesics, considering the medical history and comorbidities of the patient, and then if those comorbidities allow the patient to ingest orally the analgesic. So that box is quite new in there, and I think it's a good roadmap for you guys in order to establish the need of analgesic therapy.
So then they divided the analgesic regimens into two, so mild to moderate and the severe acute dental pain. So what is new here is that, like for mild pain, we would just prescribe ibuprofen or paracetamol. So here they combine the two, ibuprofen plus paracetamol 1000, or celecoxib plus paracetamol. And if you have any contraindication related to any medical condition or medication or whatever, you just give paracetamol 1000. So this is for mild and moderate pain. So both are the same. When in the old TG they were doing mild alone, moderate and severe, and for mild you could only give ibuprofen or paracetamol. So now you have for severe acute dental pain, so you give ibuprofen or celecoxib plus paracetamol plus oxycodone. So you don't give any more codeine, as you remember from our first show last time. You have only paracetamol plus oxycodone. Again, if the patient cannot have any anti-inflammatory, you just use paracetamol plus oxycodone. And they give you a map how to use this medication and how to taper each of them and stop. So it tells you that as the tissue heals and the patient requires less analgesia, so first you stop oxycodone because it's an opioid. We have more side effects than the rest. Then you stop ibuprofen or celecoxib, and at the end paracetamol. And they are highlighting that you need to emphasize the intended duration for the opioid use, so that the patient understands well why it's important for the patient to not use it or use it properly.
I think that's something that we need to keep in mind. We want to be responsible at the moment of prescribing a medication like oxycodone. And there's another thing that is new here, because in the old TG they were suggesting the alternative intake of ibuprofen and paracetamol. So every 2 hours you will be taking a medication. This is completely reevaluated here. I do know that specification of taking paracetamol 2 hours later the ibuprofen is quite common. But according to the new TG, this is no longer needed. If you stick to this, and the patient doesn't need to take any medications every 2 hours. So I think that's also new. and it's important to keep in mind in here as well.
And which is, I mean, relevant because like patients, they need to have simple instructions.
True.
So they are more likely to follow them.
Yeah.
If you say every 2 hours, I mean, already with the simple prescription, we could be lost, we can forget a dose or something, and then you just have to say 2 hours. Okay, that's too tricky for a patient.
That's too much, yes. And we spoke last time about the analgesic therapy that needed to be as well followed very strictly by the patient, same as we do with antibiotic therapy. So if the patient needs to take every 2 hours medication, it's more likely that for the patient to forget to take the medication because something happened, or
to stop even earlier.
Exactly, because the patient feels better, doesn't have any more inflammation. So I think all of this, and that is quite important for the OSCE, when you are communicating to the patient a particular therapy, either analgesic or antibiotic, you need to explain to the patient the importance of sticking to the entire prescription and the entire course, because it's going to do more harm than benefit if the patient stops. You know, sometimes the patients think it's too much medication. I'm just going to stop. That's better for me, but they don't realize the science behind that. So with all of this, again, and I think we are being very repetitive sometimes, but I think it's important. That you take this information, you obviously need to understand it, but you need to translate this into a real life situation. If Rada will be my patient, I will say, Rada, you need to take this, and this is why we are going to do like that. Why are we stopping first the ibuprofen and continue with paracetamol if that's what we are going to do? So the patient understands what is the reason of all these things. And I think that is important when you are doing the OSCE, because that's what the examiner wants to hear. They want to hear what is your basis, your knowledge behind that. It's not just to recommend something just for the sake of recommending. Because if the examiner asks you, and why do I need to do that? You cannot say because I read it on TG. It's not the answer. You need to come up with a simple answer that explains the patient that what we want to do is to control pain, control inflammation, but also with the minimum risk associated to any kind of medication.
And always in an easy way.
Always, definitely.
And this is, I think that they have done it because it's easier.
Yeah.
It's easier, clearer, and I mean, it is more adapted to the lifestyle of our patient nowadays.
Yeah, definitely. Yeah. Definitely, Rada already mentioned, codeine no longer prescribed. Remember, old TG, it was paracetamol plus codeine plus ibuprofen. So in the old TG, the indication was different than this, because in this one, you stop first the ibuprofen and continue the paracetamol. In the other TG, it was you are taking the paracetamol plus codeine, you interrupt that first and continue with the ibuprofen. So now it's a completely different, it's a shift of the rationality behind all of this. So you need to understand that.
Exactly.
Okay, guys, before we continue, remember, we are not live. This is a recorded episode of the show. So if you have any questions, just put it in the comment box. We will obviously go and retrieve all those questions when the video is posted, and we will try to answer the questions, in our capability. There must be things that we don't know, but we can definitely do the research and come back with a good answer for you if we can.
Definitely. So feel free. I think it's...
and how about regimens for children? We have 2 new boxes, two new tables.
I mean, this will be very helpful in your
daily
routine practice. It helps practitioner just to check the weight of the patient, the age, and straightforward know what dose prescribe.
And also, it's going to be useful on the OSCEs. Because, yes, you cannot memorize these 2 tables. But remember, if you are in an OSCE, you are going to have 3-minute reading time. When you see your case and you know that that's a children or a child, and they need to have any prescription analgesics, within those 3 minutes, you can refer to these 2 tables just to see if you go for ibuprofen or paracetamol. And according to the age, you will have an average weight, and you can choose
which
the dosage which is going to be appropriate for that. So yes, and if you ask me, I'm completely agreeing with Rada. This one is going to be next to me, you know, in my everyday life, because if I have my child patient in there, I just go to this table and I can suggest to the parent how to treat the pain.
Instead of taking your calculator.
Exactly. And I think that's pretty much it, right? Regarding everything about acute dental pain.
Yes.
So a few changes in there. So go back to this. Obviously, what we are saying here is the summarized version of everything that we have analyzed and we have read. The idea is that you guys can come back to this chapter and try to read it with new eyes and understand it even better than we are saying to you guys right now.
Now we are going to talk a bit about the temporal mandibular disorder, TMD. There's not much changes apart from the last paragraph, page 146.
Yes.
They added the Botox treatment to help, for instance, in severe cases of bruxism or TMD disorder. So basically they're saying that dentists could do it. It is within our scope of practice, but you need to have a proper training.
Yep.
So you can perform that on your patient, and it is something that you could consider in addition to the other management and the strategy that you are implementing in beforehand, considering Botox.
Yeah. Yes, I think that's the only different thing that we saw from old TG and new TG is the introduction of Botox as an appropriate adjunctive therapy for bruxism. And yeah, that's pretty much it. So probably one question could be, if I'm facing an OSCE and the OSCE is about TMJ, do I go straight away and say Botox? And the answer will be depends, you know, because you have here in the management or the bullet points of things that you need to do first. And obviously, if the patient asks or you see that Botox should be introduced in that conversation, you can mention it. Some people sometimes ask, is that something that we can say we are doing? And also it depends. It's the same thing with surgical extractions in OSCEs. Sometimes if you as dentists don't do surgical extractions, you can say that to the patient, like this is required, a surgical extraction, I will refer you. So if Botox is implicated in this particular case, you can say that definitely. If that's an alternative, if you do it because you are trained, you can say I'm trained on doing that and I can definitely do that. Or if not, I will refer you to an appropriate dentist so you can have the therapy with them. So it all depends. Doesn't mean that everything that is new here, we need to put it out there, you know? It's just when it's justifiable, then and relevant, we put it out there. So I think, again, analysis, you know, try to bring this to real life, quite important.
And also I could add that how to bring it also to the table. You can just say, again, we give our options. We say we are going to do this, but if we see that still it's not working well, we could
look for
consider a Botox therapy in adjunction to this management that I just previously mentioned. And then either you are trained and you can say, okay, I'm trained, just like Lina said, or I would refer you to a specialist.
And I think Botox has something that is quite an advantage, is that this is not a definitive treatment. It's not something irreversible.
And you
know?
need to redo it
exactly.
every 6 months.
The toxin is going to be, as a matter of speak, digested by your system. So that's also a quite conservative treatment. Yes, the patient needs to go and top it up every certain time. But if you think that this kind of treatment, which I personally consider conservative, is something that you want to propose to the patient, definitely you can do it. It's there for a reason, so it's already, you know, validated by Australian Dental Association.
Exactly.
Okay, burning mouth syndrome, pretty much the same.
Yeah.
Yeah, that's pretty much the same for probably, diagnosis and management, you know, it's something that has been...
It's just a bit
organized.
Organized.
Yeah. So that's pretty much about,
Now, Bruxism.
Yeah, Bruxism.
What we spotted is more about the... so they added a little paragraph just for the sleep bruxism management. So they brought kind of several therapies, relaxation technique, hypnotherapy, biofeedback, and so on. And they have also brought another management for the awake bruxism, which is about habit recognition and reversal, stress management, and so on. So they don't give any percentage anymore.
Yeah. And
they give you a proper management for both.
Exactly. And I think what is curious about this particular part is that if you read this, the first line of management is not something related to dentistry. You know, they mention obviously towards the end of the chapter about the occlusal splint, and they give some recommendations in there. But if you see these relaxation techniques, hypnotherapy, biofeedback, I mean, this is not something that we as dentists do, you know, unless you are trained in this particular field. I have no idea how to do cognitive behavioral therapy.
Me neither.
But you are a mom, you know how to do that.
It's another field.
So if you read these guys, you will see that the management of bruxism is quite complex. So don't try, if you get an OSCE related to that,
just to jump into the splint.
To jump into the splint, you know?
It's a part of it.
It's a part of it, and definitely has been discussed widely that the causes of bruxism are pretty much unknown. You know, everyone says a different thing. That anxiety, that depression, stress. Stress is pretty much the cause for everything in this world nowadays, you know? So it's a very tricky and complex kind of disease to treat. So you need to explain the patient that definitely the patient goes to the dentist most of the time because they feel, you know, the things in the face. So obviously we are the first line of management in there. But it will be very nice to see someone exposing to the patient to tell them like, look, this is a complex situation. From my end, this is what I can do, but that's not going to resolve the problem. Technically, nothing is going to resolve the problem. But we have these other techniques. If the patient is open to it, obviously if the patient has mild or moderate bruxism, the patient will be okay with the occlusal splint. Probably the patient doesn't go, to go to have any of these treatments. But I have seen so far here in Australia a lot of patients that struggles a lot with bruxism. A lot of patients. So I'm sure that if bruxism is getting in their lives, they will be open to hear about this particular thing.
To have a comprehensive management, not only jumping into the splint, but rather having a comprehensive approach, management to also reduce the level of bruxism, of anxiety, and so on, and to have a better lifestyle. Hygiene and lifestyle.
Correct. And Rada just said something quite important. Remember that in OTG and also in UTG, they mention the difference between treatment and management. That's why every single thing that you see here is about management and not treatment. Treatment is the occlusal splint. I'm treating something with that. But management is what just Rada said, you know, taking into account all the social, environmental factors that are causing or adding to these presentations. So keep that in mind, because when you go to an OSCE, the second cluster is about diagnosis and management, not diagnosis and treatment, because there's a difference between treatment and management, and that's written in both TGs.
Yeah, correct.
Okay,
they just removed the part of the splint, NTITSS.
Basically because it's not relevant anymore, because they discovered that splint was only covering a part of the anterior teeth, just to deprogrammate the patient, the muscles, but that can create some extrusion and occlusal changes. That's why
aspiration
as well, because it's very tiny. So they are recommending here now that if you're doing an occlusal split, it needs to be a full coverage one, so you can avoid any occlusal changes in the patient.
That's
and trismus is pretty much the same. So I think that's pretty much for this chapter, guys. Again, don't take our word.
Do your research.
Do your homework.
Read carefully. Try to fully understand, and swallow the thing. Rather than just following blindly.
Exactly.
You need, like Lina said, to digest the things, so you're more likely to memorize and to have
interiorize things when you understand
them. To have a good approach as well during your OSCE with your patients in real life.
And remember, leave your questions in the comment box. The more you read, the more valuable the interaction between you guys and us is going to be. More good for you, because if you have read, if you have analyzed, the level of complexity of your questions probably is going to give you a lot of value.
And will rise as well.
Oh, and also it's going to be, obviously, we need to step up as well, to try to bring the conversation to that level. So definitely we are happy to do that. We have enjoyed this, and I will see you guys, or we will see you guys in the next episode.
Bye-bye. Take care.